So, hello students. Now that we have discussed the clinical anatomy, the clinical case series of upper limb and lower limb, let us now understand the important clinical presentation of the thorax. Like what are the case-based scenarios that you're going to get in the thorax, how to approach these questions and how to answer them efficiently. Okay, students. So let us begin with the first clinical question of thorax. Have a look. A 36-year-old man had a chest tube placed for a large pleural collection. So a chest tube is placed to remove the pleural fluid, the pleural collection or the collection of fluid in the pleural cavity. 2 days later, he develops prominent medial scapular winging and difficulty in pushing against a wall. Okay, so what do you think? Like a tube is placed in the pleural cavity to remove the fluid. Okay, so when we are placing the tube, we are passing through the intercostal space and we are entering, we are piercing the thorax, the layers of the thorax, the skin, the superficial fascia, the deep fascia, the serratus anterior muscle. Yes, then external intercostal, internal intercostal, innermost intercostal. Then we come to a fascia of the thorax, that's the endothoracic fascia. And finally, we pierce the parietal pleura. We enter the pleural cavity and we place the drain there. We are not going to touch the visceral pleura. Correct, students? So what are the various layers that we are going to pierce clear? Skin, superficial fascia, deep fascia. Yes, the serratus anterior, external intercostal muscle, internal intercostal, innermost intercostal, endothoracic fascia, the parietal pleura. So these are the various layers that we are going to pierce as we are putting the drain in the pleural cavity. Fine. So as we are putting the drain, we are cutting through the serratus anterior muscle, and there's a nerve which runs on the serratus anterior, the nerve which supplies the serratus anterior, the nerve which begins from C5, C6, C7 roots of the brachial plexus, and this nerve is generally damaged as we are passing through the lateral aspect because the nerve is running on the serratus anterior, right? So which nerve is most likely to be damaged? What do you think? Yes, what is the answer? What is the nerve most likely to be damaged? That's the long thoracic nerve. Long thoracic nerve or the nerve to serratus anterior. That's a long thoracic nerve. Long thoracic nerve is also known as the nerve to serratus anterior or the nerve of Bell. What is the root value? C5, C6, C7 arises from the roots of the brachial plexus. Correct? Very good. Very good. Which muscle is paralyzed? Come on, what does the long thoracic nerve supply? It supplies the serratus anterior muscle. Supplies the serratus anterior. You know the origin of serratus anterior. It begins from the lateral aspect of the upper 8 ribs as digitations. And this muscle comes and gets inserted on the medial border of the scapula on its costal aspect. Medial border, costal aspect. What are the actions of serratus anterior? It helps in pushing and punching movements. That is protraction of scapula. Protraction of scapula. Second, it helps in overhead abduction along with trapezius, right? So what are the actions of serratus anterior? Number 1, protraction of scapula. Second, overhead abduction along with trapezius. And number 3, it also steadies the scapula. It steadies the scapula during weight carrying. During when the weight is lifted here on the shoulder, it steadies the scapula. Okay. So that's fine. So clear, you got an idea about the serratus anterior, you got an idea about the nerve to serratus anterior, you've understood what is the action, origin, insertion, nerve supply and action of serratus anterior. Correct, students? Very good. Why is the nerve at risk around the chest drain level? Because see, when the drain is inserted from the lateral aspect of the chest wall, we are going to encounter the serratus anterior muscle and the nerve is running on the serratus anterior. So this nerve would most likely to be damaged while piercing the muscle. The nerve may be damaged. So see the last time, see our question, what small change in the anteroposterior placement reduces the risk? So we go slightly anterior, not exactly lateral, we go slightly anterior in the intercostal space. So we avoid the risk of damaging the nerve which is running on the serratus anterior on the lateral aspect. right? So we go slightly anterior in the intercostal space and then we enter the space. Fine, students. So this is very common. Pleural effusion. Pleural effusion occurs between which two layers of pleura? The parietal and the visceral layers of pleura. There's accumulation of fluid. Okay, that is known as pleural effusion, and we have to tap the pleural effusion to reduce the discomfort which the patient has. Clear? I hope this question is clear to all of you. Very important. Everything about the intercostal space also you have to know. Okay, let us see in some other MCQ. I'm sure this is clear to all of you. So thank you to all of you, and make it a point to see the previous lectures also, the clinical series of upper limb and lower limb. And these questions go in a sequence. See the questions till the end, so you get a overall orientation of all the topics of the thorax. Beginning from the intercostal space, we go to the lungs, we go to the heart, we go to the diaphragm, everything gets covered. Okay, students, you can follow this Instagram, you can follow this Telegram group and the YouTube channel. Okay, there are many other things which are there on the YouTube channel also, like important questions of various topics are there in my YouTube channel also. Okay, students, thank you and see you all in the next lecture.